I'm a geriatrician, a physician who specializes in aging and what it does to the human body. And I need to tell you something that most doctors in my field don't say loud enough. The difference between a 75-year-old who carries their own groceries, climbs stairs without holding the railing, gets down on the floor to play with a grandchild and back up again without help, and a 75-year-old who can't do any of those things. That was almost always decided 10 to 15 years earlier, not by genetics, not by a single diagnosis, not by luck, by what they did or chose not to do with their body during their 60s. I see this every week. Patients in their mid 70s who come in for something routine, and within the first 90 seconds, the way they lower themselves into the chair, whether they need the armrest to stand, how they walk from the waiting room to the exam table, I can see which trajectory they've been on. The ones on the harder trajectory almost always tell me the same thing. They had some discomfort in their 50s or early 60s. They backed off from activity. They rested more. They meant to get back to it. Then years passed. That story is the one I want to interrupt today, because by the time it ends in my office, the options are narrower. If you're over 50 and dealing with any joint stiffness or pain, knees, hips, lower back, shoulders, anywhere, what I'm about to share is the conversation your primary care doctor almost certainly hasn't had time to have with you. Not because it's specialized, because the typical 15-minute appointment isn't designed for it. I want to tell you who this video is specifically for. If you're in your late 50s, 60s, or early 70s and joint discomfort has caused you to modify how you move, you've stopped certain activities, you avoid situations where you might need to kneel, sit on the floor, or climb more than one flight of stairs. This is the conversation you've been missing. Most of my patients, like you, were never told what is actually happening inside their muscles and joints during that period of reduced movement. Most were given a prescription or told to take it easy. By the end of this video, you'll understand the underlying mechanism clearly enough to make genuinely informed decisions about what to do next. Here is what you need to understand about your body after 50. There are two things happening simultaneously, and most people only know about one of them. The one people know about is joint wear. Cartilage, the smooth protective tissue cushioning the ends of your bones, does degrade with age. It becomes thinner, less resilient, slower to repair. That's real. But here's what most people don't know. Cartilage has no direct blood supply. It cannot feed itself through circulation the way other tissues do. The only way cartilage receives the oxygen and nutrients it needs to stay viable is through a process called imbibition. The cartilage absorbs synovial fluid, the natural lubricant inside your joint, when pressure and movement alternate across its surface. Compression release, movement stillness, compression release. That cycle is what keeps cartilage alive. When you stop moving, even moderately, even for a few months, cartilage begins to thin not just because of age, but because it's being starved. The delivery mechanism for its nutrients stops working as designed, and because cartilage doesn't repair quickly, even under ideal conditions, what's lost during a prolonged sedentary period doesn't come back easily. But that's the first mechanism. The second one is the one that actually determines whether you see your grandchildren grow up. And it almost never comes up in a standard appointment. It's called sarcopenia. The word comes from Greek, sarx for flesh, penia for poverty. It means the progressive loss of skeletal muscle mass and strength that begins in your 30s and accelerates sharply after 60. Work published through the National Institute on Aging estimates that sedentary adults can lose 3 to 5% of muscle mass per decade, and that rate more than doubles after 60 for people who don't actively counteract it. The American Geriatric Society has identified sarcopenia as a primary driver of functional decline. Difficulty standing from a low chair, trouble climbing stairs, the loss of balance that leads to falls. And here's the part most people miss. Muscle loss isn't just about strength. The muscles surrounding your joints are your joint's primary protection system. They absorb impact, control movement, and distribute the weight of your body evenly across the cartilage surface instead of letting it grind on one spot. When those muscles atrophy from disuse, the cartilage beneath takes more load, more pain, more stiffness, more inflammation. Not because the joint has suddenly worsened, but because the structure that was protecting it is no longer doing its job. There is a third piece because it connects directly to fall risk. It's proprioception, your body's continuous sense of where it is in space. Specialized nerve endings throughout your muscles and connective tissue send constant position signals to your brain, where your knee is, how your ankle is angled, how much weight is shifting toward your left hip. This system keeps you upright on uneven ground and helps you catch yourself when you trip. Proprioception degrades with inactivity. The nerve pathways involved need regular use to stay calibrated. The CDC reports that falls are the leading cause of injury-related death among adults 65 and older. That statistic doesn't start at 65. It accumulates during the years before. The most common mistake I see adults in their late 50s and 60s make is treating joint pain as a reason to stop moving, when movement is precisely what the joint needs to stay viable. Rest reduces acute pain in the short term. Prolonged rest accelerates every one of the mechanisms I just described. And by the time the consequences become visible, months or years have passed. Let me give you 5 specific things that follow directly from that biology, not generic suggestions, things I actually discuss with patients in my clinic with the reasoning behind each one, because the reasoning is what makes them stick. The first is establishing a daily minimum movement threshold and understanding why threshold matters more than duration. Most people think in terms of exercise sessions, 45 minutes 3 times a week. The problem with session-based thinking is that it leaves enormous gaps. 22 hours of sitting followed by 45 minutes of movement does not produce the same outcome for joint health or muscle maintenance as movement distributed across the day. The research on sedentary behavior interruption is consistent. Breaking prolonged sitting every 40 to 60 minutes, even with 2 to 3 minutes of walking or gentle movement, produces measurable differences in inflammation markers, circulation, and joint lubrication. For patients who tell me they walk 3 times a week, I explain that the 23 hours in between matter as much as the walk. The threshold is not about hours logged. It's about not leaving the joint mechanism dormant for longer than it can sustain. The second intervention addresses a muscle most people over 60 have never connected to their joint pain, the hip flexor complex. You have a group of muscles running from the front of your lumbar spine through your pelvis to the inside of your upper thigh. In adults who sit for extended periods, and most Americans over 60 sit for more hours than they realize, this muscle group becomes chronically shortened. Because it attaches directly to the lumbar vertebrae, a shortened, overactivated hip flexor creates a constant pull on the lower spine, tilts the pelvis forward, compresses the lumbar discs, and alters the load pattern across the hip joint. The consequence is a cascading postural shift that affects every joint from the hip to the knee. Patients come in convinced their knee is the problem. I look at the hip, at how the pelvis is oriented, and frequently the knee is just the loudest downstream consequence of a problem that started 2 joints higher. The intervention is a daily hip flexor lengthening sequence held in a low load position for 60 to 90 seconds per side, but it must be done consistently. This tissue does not respond to intermittent effort. If this is the kind of explanation you've never gotten in a clinical setting, I want to ask you to press subscribe and leave a like on this video, not for my benefit, because this kind of content built around clinical reasoning rather than quick tips needs to reach more people over 60 who are making decisions about their bodies without this information. The algorithm moves it toward the people who need it when you engage. That's the most direct way to help. The third intervention is balance training, and I want to be precise about what I mean. It means challenging the proprioceptive system, the nerve pathways that tell your brain where your body is in space. The most effective way to do this without equipment is single-leg stance work with a sensory challenge, standing near a counter or chair for safety, lifting 1 foot 2 inches off the ground, minimizing sway for 15 to 20 seconds, then increasing the challenge by closing your eyes, removing the visual input your brain uses as a substitute when proprioception is weak. Research from the hospital for special surgery and similar institutions consistently shows that balance training 2 to 3 times per week, even in brief sessions, produces measurable reductions in fall risk in adults over 65 within 6 to 8 weeks. You're not just strengthening muscles. You're recalibrating the neural system that controls position awareness. Give it no stimulus, it deteriorates. Give it consistent progressive challenge, it adapts. The fourth addresses the overnight stiffness problem. Your intervertebral discs, the gel-filled structures between each vertebra that act as shock absorbers, spend the night under reduced load while you sleep. After 60, this period of reduced loading causes the surrounding musculature to stiffen significantly. The paraspinal muscles, the long columns of muscle running alongside your spine, contract. The fascia, the dense connective tissue wrapping these muscles, stiffens as its temperature drops. You wake up, and for the first 30 to 60 minutes, your spine is genuinely less mobile than when you went to bed. Most people in their 60s recognize this and power through it. The better approach is a brief morning reactivation sequence, gentle spinal rotation in a supported lying position, slow hip circles on hands and knees, cat-cow variations, done for 6 to 8 minutes before you stand and begin the day. This is not exercise. This is priming. You're using movement-generated heat to restore tissue elasticity before loading the joint under gravity. The fifth is the one that matters most on the days you feel worst and the one most likely to be counterintuitive. When joint pain flares, when you wake up and everything hurts more than yesterday, the near universal instinct is to stop moving, to rest, to protect. For the vast majority of adults with chronic joint pain, this is the wrong response. When you rest a flared joint completely, synovial fluid becomes stagnant, waste products accumulate. The surrounding tissue, deprived of gentle movement, becomes more sensitized, not less. The joint stiffens further. When you finally do move again, it hurts more than it would have had you maintained gentle movement throughout. A review published in the Journal of Orthopedic Research found that gentle, low-load movement during inflammatory flares consistently outperformed complete rest in recovery time and pain reduction. The key is low load, not pushing through. Ankle circles from a seated position, shoulder rolls, 10 steps across the room. The joint needs circulation. Rest denies it. I want to say something here that I did not expect to be saying a few years ago because it describes a shift in my own practice that I resisted for a long time. For most of my career, my approach to patients who needed structured movement was consistent. I referred them to physical therapy, in-person supervised, individually calibrated. That was the gold standard in my mind, and I defended it whenever anyone suggested patients could manage through at-home programs or digital tools. My skepticism was not philosophical, it was practical. I had seen too many patients attempt to follow instructions they found online that were designed for someone 30 years younger, with no feedback mechanism to tell them when something was wrong. What changed was not my beliefs, it was what I was observing. A significant portion of my patients over 60 were not going to physical therapy, not because they didn't want to, because insurance covered 6 sessions when they needed 30, because the nearest rehabilitation center was 40 minutes away and they no longer drove at night, because the out-of-pocket cost was $90 per session on a fixed income. These patients were leaving my office with a referral and returning 6 months later without having used it. I was handing them the same referral again as if the barrier had somehow changed. I started asking different questions. What would these patients actually follow through on? What structure would fit into a life with real constraints, financial, logistical, physical? Over time, I incorporated into my recommendations a structured program in digital format, one I now use with patients who fit a specific profile, over 60, dealing with chronic joint stiffness or mild to moderate pain, unable or unwilling to engage with in-person physical therapy consistently. The two components that are most relevant for what this episode addresses, the muscle loss and proprioceptive decline I described, are the micro sessions and the progressive 8-week plan. The micro sessions are 5 to 7 minute mobility blocks designed to be done daily at home without equipment. The reason they work is not the duration, it's the frequency. A 7-minute session every morning does more for joint lubrication and muscle activation than a single hour-long session twice a week, because the cartilage nutrition mechanism, the movement of synovial fluid, the proprioceptive stimulus all respond to regularity, not volume. The progressive 8-week plan eliminates the decision burden entirely. Patients who tell me they start strong and then lose the thread aren't lacking motivation, they're lacking structure. The plan specifies what to do on day 1, week 2, week 5. The progression is calibrated and it doesn't push too fast, which matters specifically for adults over 60 whose connective tissue needs longer adaptation windows than it did at 40. What I've observed clinically, and I want to say this precisely as a documented pattern rather than a promise, is that patients between 63 and 71 who used this structure consistently reported meaningful improvement in morning stiffness and their ability to perform basic functional movements within 4 to 6 weeks of consistent practice. Not in every patient, but consistently enough across a specific enough profile that I've maintained it as part of my recommendations. This program is an educational, structured framework for daily movement. It is not a medical treatment. It is not a substitute for individual evaluation for patients dealing with acute conditions or complex diagnoses. But for the patient who is chronically stiff, dealing with mild to moderate joint discomfort, who has been told to move more without being told how, it addresses a real gap. The link is in the description if you'd like to look at it on your own time. The divergence between two people of the same age and same starting point becomes unmistakable by 75. I had a patient recently, a 78 years old routine visit, gets himself up from the waiting room chair without touching the armrests, drives himself. Went to his granddaughter's school play last week. Another patient, also 78, same month, holds both armrests to stand, tells me she mostly stays home, that going out requires planning and help, that she stopped attending family events that involve standing for long periods, same age. When I look back at what each of them was doing in their early to mid 60s, the pattern is as consistent as anything I see in this field. What makes sedentary behavior in the 60s specifically consequential is the compounding rate of the mechanisms I described. Compensatory movement patterns become habitual and generate secondary problems. A patient who favors one leg to protect a knee will develop hip pain on the opposite side within 2 to 3 years, then lower back involvement from the pelvic tilt. The original knee problem becomes the first domino. The relationship between mobility and autonomy after 70 is a list of specific actions: rising from a toilet seat without grabbing the wall, stepping out of a bathtub, picking something up from the floor, getting into and out of a car, walking 2 blocks without stopping. Patients lose these capabilities one by one. Each loss shrinks what is available to them. Because the shrinkage is gradual, most don't notice it until something significant is already gone. What I've covered here comes down to three connected realities. The mechanisms driving joint pain and functional loss after 60, sarcopenia, cartilage starvation, proprioceptive decline, are progressive but responsive. They respond to structured, consistent movement stimulus. The most dangerous response to joint pain is also the most instinctive, stopping entirely. And the window of favorable response exists, and it narrows with each year of inactivity, not dramatically, but measurably. Before I close, I'd like to ask you something in the comments, and I mean this genuinely. Tell me in the comments, what's one physical thing you could do without thinking 5 years ago that has become harder or that you've stopped doing altogether? That answer tells me and tells you exactly where in this process you are. What I've shared here is education, not a personal diagnosis and not a substitute for individual guidance. If you're managing a specific condition under a doctor's care, talk to that physician before changing anything significant in your activity pattern. That's not a formality. That's sound medicine, and it's the first thing a responsible clinician says. For those of you dealing with chronic stiffness, some pain, no acute diagnosis, just a body that has gotten quieter and more cautious than it used to be, the structured program I mentioned is in the description below and in the first pinned comment. Look at how it's organized. Evaluate it. If the format fits your situation, that is the kind of daily progressive structure that produces the results I described. Here is what 26 years in this field has made clear to me. Every week you delay deciding to move consistently is a week your fast twitch muscle fibers, the fibers responsible for catching yourself when you trip, for the stabilization that turns a stumble into a recovered step, are adapting to smaller demands. Those fibers respond less readily to training with each year of inactivity, but they still respond. The patients getting out of the chair in my waiting room without touching the armrests at 78 made that choice in their early 60s, often without fully understanding what they were deciding. You understand it now.